Welcome guys to another video for our return demonstration. Our topic for today is about knee x-ray, and with my patient, my mother, a 63 years old female, experiencing stiffness and lacking of joint, weakness or instability, difficulty on moving or straightening of the knee.
Good morning po ma'am. Ulitin lang po natin yung information nyo. Kayo po si Ma'am Vivian Ramos, 63 years old female. For diagnostic knee x-ray for suspected arthritis po. Tama po ba?
Opo.
Ano pong nararamdaman nyo ma'am?
Sumasakit yung tuhod ko, nahirapan akong lumakad.
Sige po ma'am. Diretso na po tayo sa x-ray room. Magbihis na po.
Before starting any procedure, make sure to ask for patient consent when positioning the part of the body.
Before po tayo mag-start ng procedure, okay lang po ba na hawakan natin yung part ng x-ray natin? Okay po, thank you.
AP projection of the knee. Adjust patient's leg by placing femoral epicondyles parallel to the film, 3 to 5 degrees internal rotation. Central ray is directed to a point ½ inch inferior to patellar apex. Central ray depends on the pelvic thickness. As a less than 19 centimeters, it is 3 to 5 degrees caudate or thin pelvis. A thickness of 19 to 24 centimeters is equal to a 0 degree central ray. But with a greater than 24 centimeters, 3 to 5 degrees cephalad is applied. PA projection of the knee. Place the patient in the prone position with toes resting on the radiographic table, or place sandbags under the ankle for support. Positioning of the part, center a point and ½ inch below the patellar apex to the center of the IR, and adjust the patient's leg so that the femoral epicondyles are parallel with the tabletop. Because the knee is balanced on the medial side of the obliquely located patella, care must be used in adjusting the knee. Central ray, directed at an angle of 5 to 7 degrees caudate to exit a point of a ½ inch inferior to the patellar apex. Because the tibia and fibula are slightly inclined, the central ray is parallel with the tibial plateau. A perpendicular central ray may be needed for patients with a large thigh or when the foot is dorsiflexed. For suspected osteoarthritis, AP projection, weight-bearing method, standing. Adjust the patient's position to center the knees to the IR. Ask the patient to stand straight with knees fully extended and weight equally distributed on the feet. PA projection, Rosenberg method. Place the patient in standing position with the anterior aspect of the knee centered to the vertical grid device. Place the femora at an angle of 45 degrees. Since the patient cannot assume a mediolateral lateral projection, we're going to move into a AP oblique projection lateral rotation. Place the patient on the radiographic table in the supine position and support the ankles. Position of part. If necessary, elevate the hip of the unaffected side enough to rotate the affected limb. Support the elevated hip and the knee of the unaffected side. Center the IR ½ inch below the apex of the patella. Externally rotate the limbs 45 degrees. Always shield gonads. Central ray is directed at a 1.5 inch inferior to the patellar apex. The angle is variable depending on the measurement between the axis and the tabletop as follows. As less than 19 centimeters, 3 to 5 degrees caudate is applied. 9 to 24 centimeters, 0 degrees. Or greater than 24 centimeters is at 3 to 5 degrees cephalad. Collimation is 10 by 12 inch on the collimator. Structure shows. As for medial rotation, the position of part is medially rotate the limb and elevate the hip of the affected side enough to rotate the limb 45 degrees. Place support under the hip if needed. Shield gonads. Central ray is directed at a half-inch inferior to the patellar apex. The angle is variable depending on the measurement between the axis and the tabletop. Collimation. Adjust 10 by 12 inches on the collimator. Structure shown.